This masterclass is on how to play USMLE on cheat codes, which is test taking skills. If you've ever played a game on cheat codes, life just gets so easy on cheat codes. You have unlimited ammo, unlimited credits, unlimited points. You can buy anything, you can do anything. These cheat codes will allow you to play in your limitless potential. And these are my score reports: 260, 271 on the step 1 and step 2 in the 99th percentile. So in this masterclass, what I will be taking you over is just how to play the game of USMLE on ultra easy mode using cheat codes. And what was the 270 plus strategy that got me like a step 2 score of 270, 260 on step 1. In this, I'll go over testing cheat codes, which is pattern recognition, clue recognition, elimination, and differential diagnosis algorithm. Learning on cheat codes, which is unidose learning, how to learn and never forget. Encoding variability, it's a replacement for revisions. So if you look at revisions are boring. You have to keep going across the same concept from the same resource multiple times. And that creates boredom, burnout, and frustration. We want to switch that for something more fun. And that's called encoding variability. It's a new discovery in learning science on how to accelerate learning so that you don't forget and you retain information for a long time. And lastly, progressive summarization. How do you remember big chunks of data? How do you compress them and never forget about them? That's through progressive summarization. And then learning using test taking. So what people think is if you know cheat codes, that's just going to increase your performance on the test. But what it also does is this, it allows you to learn better. Because once you know how the game works, what is the source code of the programming of USMLE, you can now learn in a more focused way. You now have a better lens to see what to learn, what not to learn. And that's why testing skills are very critical. In the end, for those of you who stick till the end, we'll do a special gift for anyone who sticks till the end. So let's get started with the cheat code masterclass. Let me show you how powerful this is. So this is me in my first pass of UWorld. I have a video on this on how to do UWorld, how to perform really well on UWorld and learn from it. This is my first pass percentage of UWorld. If you look at this, these are all timed. 40 questions. The first time I did it in 2019 and I took 7 months. So the first time I did UWorld, I had a 93% correct rate. So out of all the questions, I got 2,677 questions correct. And I was in the 90th percentile. This is my first time in UWorld. And people don't believe it, but this is the power of if pattern recognition, clue recognition. If you know how to do test taking, this is the kind of results you get. And these are my percentages, individual percentages on timed mode that I got. 80 to 97 minimum, 80 you would see. And maximum, I think 100% is how far I got. If you look at my NBME, so these are my NBME practice tests, and this is form 20 at that time. So currently you're in the era of newer forms, but at my time it was more form 20 or form 24. This is my first form. I started it in 2019, so December 12, 2019, and this is where you will see the 2019 here as well. And this is when I was done with 30% of UWorld, and my step 1 score was 261 with 30% of UWorld done. So if somebody tells you that UWorld is responsible for them scoring well, that is bullshit. UWorld is a resource. It is not the Bible that will teach you somehow on how to score like crazy on the USMLEs. And form 21, if you look at December 22, I didn't go above more than like 40% or 35% on UWorld. Form 23, and you can see my scores, 263, 266, 264, while doing not much of UWorld. My UWS scores were 279 and 271 using these strategies. This is my step 2 CK percentage on first pass. This is my step 2. I took a screenshot and you can see I was in the 94th percentile first time doing it. Didn't do a lot of other resources and I got most of the questions correct at this time. Out of 3,687 questions, I'd used 3,343 and my correct rate there was 85% and only 15% were incorrect. Most of the people who even do UWorld don't get like the first time. In second pass, people don't get these kind of results. I was able to obtain it in my first pass. And this is all the beauty of testing skills. I wanted to just share with you my UWS scores for step 2. I got a 293 after my first pass of UWorld. And this was with a correct rate of 96% and only incorrect was 4%. So that is the superpower you want to have. Those are the cheat codes you want to have if you want to go to the exam and not be worried and just relax. I was enjoying the USMLE because of this. Secondly, you will see my UWSA score of this was a UWSA 2. A UWSA 2 score was 276, 91% correct rate and only 9% incorrect. And these are the crazy results you get. So that's the superpower I want you to have using test taking skills. So without test taking skills, you're in a never ending cycle of self-doubt where every decision feels like a potential mistake. You're always criticizing yourself, judging yourself. Is this A? Is this B? Is it C? Is it D? Is it E? Is it F? And it is a headache. Now imagine doing that for entirety of UWorld, entirety of NBME questions. You're going through at least minimum 5,000 to 6,000 questions before you go to step one. And then in step one or step two, you are in a constant state of anxiety, doubt, where which answer should I go with? Without testing skills, that's how it's going to feel like. You're going to have constant anxiety, frustration, and dread. That's what my students told me before they learn testing skills. There's always going to be overwhelmed with the resources because people tell you, do this resource, do that resource, it will fix that. The answer generally is not the resource. It's just that they learned everything wrong because they never knew testing skills. They never knew what to learn because they never could see it. It's like seeing the matrix. If you don't know the testing skills or you don't have those glasses, you won't be able to see those patterns and learn from them. And then you fatigued all the resources, scores don't improve, and it's just like a mess that you have to deal with. And the fear of failing comes from not knowing testing skills. So when I was giving my USMLEs, I'm going to tell you, I was excited as hell. I was like, I'm going to enjoy this exam. And before the exam, I knew I was going to pass. I was going to 270s minimum because it was just so easy for me. And I knew knowledge. I didn't need to do every NBME on the planet or every sketchy, every boards and beyond video. And I had no shame of disappointing anyone. So many people have shame of disappointing themselves if they don't perform on the test. The reason that comes to be is because, again, they don't know testing skills. With testing skills, what's going to happen is this. They're going to help you come to the answer without always knowing the answer, which is a superpower. Probabilistically, let's see how that works out. So if they increase performance on every single question on the test. So if you have knowledge, let's say A, B, C, D, we'll go back to the same point. If you have knowledge, you'll be able to come to the answer A. That's going to be like, let's say you learn knowledge, you're learning a lot, will give you an upper hand on one question. But if you are able to rule things out, let's say C is the answer here, but you're able to rule things out, you no longer have to go crazy after knowledge always. It's important to learn. I'm not saying you shouldn't, but the resource overwhelm that comes is coming from assuming that you have to know the answer. If you figure out a way when you don't know the answer, that's how it will pan out across 320 for step 2, 280 for step 1, and that will lead to a massive score improval. Even if you don't know the answer, let's say you're stuck between C and D, that is a way better position to be in than to be in a position where there's 5 answer choices and you can't rule things out. The probabilistic estimate of guessing there is about 20%. However, if I'm able to rule at least 3 out, my probabilistic estimate of getting it is 50%. And that's how you at least ensure a pass. So if I have that probabilistic estimate across one question, that's one thing. But imagine doing it across every single question, how powerful that will be. That marginal gain is what leads to exponential improvements on the test scores, not just knowledge. And that's what is very important to learn. And what these testing skills allow is consistency and reliability across all exams by ending the endless maze of guessing. You're no longer stuck. And this is what I'm trying to tell you. If you look at my consistency, 97, 97, 98, 80, 97, 90, 87, all of that, like if you look through my test scores, all of this consistency and reliability is coming because I know testing skills. And they significantly boost question-based learning through surgical precision. I'll show you how this works when we go back to the last question and use test-taking skills to dissect it. You're no longer in plateaus. They end the powerlessness where you feel you're guessing all the time. You don't feel powerless. We have gotten crazy results, which I want to share with you. The kind of results that I've gotten people, this is somebody who wrote on my YouTube channel, she got a 280 plus on step 2. And she wasn't, again, the smartest individual, but she followed the strategies, she followed the testing skills that I teach, and that got her a 280. And apart from that, I've worked with multiple other students. This is just a few of the screenshots. One of them is from the Middle East, got a 50-point increase following Exponential Advantage, which is my course. Somebody from Jipmer got a 268. This is Cameron. She is one of my students. She's from Spain. Now she's working in the US as a resident. She initially was failing on her NBMEs, but later on, after we got her trained in testing skills, her scores jumped by 50 points, which was crazy. You don't have to be a genius. You don't have to do every freaking resource on the planet. You don't need to know the answer to every question. What you need is the ultimate cheat code which are test taking skills. And what are test taking skills? Before I go into that, we are going to go through a question stem together. This is a typical USMLE question stem where we're just going to read this question and see how we do. And let me know the answers you have to this in the chat, and let's see how many of you get this correct. And we'll use test taking skills. So I'm going to teach you, I'm going to take your hand, and I'm going to teach you how to do this. And then we are going to learn how to use test taking skills to accelerate learning. Okay. So in this question, so 75-year-old woman is brought to the emergency department after her losing consciousness at home. She has a history of getting up from bed and falling and losing consciousness for several seconds. She has a history of atrial fibrillation, hypertension, and angina. Currently on aspirin, chlorthalidone, warfarin, nitroglycerin. She is afebrile, pulse is this much, 110, regular. Blood pressure is 98/52. She has a dry tongue on physical exam findings. Capillary refill is 4 seconds, and cardiopulmonary examination is normal. Further evaluation of this patient will show what? Is it increased troponin? Is it elevated P waves, absent P waves on ECG, elevated BUN, left ventricular hypertrophy, a clot in the popliteal vein on compression ultrasonography, or a friction rub on auscultation? I want you guys to put whatever you think the answer choice is in the chat. And let's see how many of you get that correct. So somebody said LVH, clot in popliteal vein, absent P waves. Okay, I have a question. So for all you guys, out of you who said clot in popliteal vein, what made you say clot in popliteal vein here? You can just type that in the chat. For all of, could you also give me reasons? Like I see like good reasons for some people said BUN is hypovolemic shock. But I also want to ask you, isn't she having AFib? So doesn't absent P waves happen in AFib? Somebody said LV, she has hypertension. So let me ask you a question. If she has hypertension, if you look at her history, couldn't she have LVH, left ventricular? So what I'm trying to bring the point across here is this. And guys, I know you're raising your hands. We can again do a personal Q&A later on. You can just type in the chat, but so this is the question we had. We'll solve this question later, but I just wanted to show you this is how a typical USMLE question looks like. Every answer choice looks like it's the answer choice, and it's not something that's going to be given that easy to you. Okay, so what I would teach you here is you're not ever going to know everything on the test. Even if you know, they're going to confuse the hell out of you. And if that's the case, the way to get to the answer, again, there are different ways. You could know the answer here. So if A, B, C, D, if you look at different answer choices, A, B, C, D, E, you could know it's A or is it B. That's knowledge. That's a knowledge derivative path. So I could know the answer is A based upon knowledge. But if I don't know the answer, how do I come to this answer? The way I come to the answer is by ruling B, C, D, and E. And the easiest way to pass the USMLE and score high on the step 2 is using elimination. And this is through certain clues and patterns the question writer will give you. And for example, history is a certain clue. Here you can see a history of hypertension or AFib. That is a certain clue they're giving you. Age, she's 75. Is that like something that's a risk factor for LVH? Or is that a risk factor for something else? AFib getting worse, sick sinus syndrome, sex. So male versus female, that's a certain clue because certain diseases happen more commonly in males versus female. Ethnicity, you will see certain diseases happening more in the Caucasian population than the Asian population. Example, thalassemia, and that itself is a clue. Physical examination findings, which you will get in the question. So you're getting there, and laboratory findings. So these are all certain clues you can use to rule out these answer choices and come to the answer, which might be A. The answer here is, I'm not sure if it's even A, but that's kind of what I'm trying to teach you is there's one way, knowledge. You could read thousands of books and try to do that. And if you want to, sure. But the other easiest way is rule things out. Okay. The way we are going to do this is through two main skills. One is pattern recognition. So remember, USMLE will test you on the most common patterns of a disease. They're not going to give you an atypical presentation where tuberculosis is causing abdominal issues. They're going to always give you TB, which is causing lung pathology, not abdominal pathology. They don't care. Like what they want is a physician who can address the most common pathologies, not the rarest pathologies. That's the point of this test taking that they're trying to do here. So what they will typically give you is example for DVT. They'll give you a woman who's 35, female, smoker, or uses OCPs, or is pregnant. So it's a virtuous triad, hypercoagulability. And all of a sudden, she's going to develop a swelling on one leg, and that's going to cause a pulmonary embolism. So this is the most common clinical presentation in the US that you're going to see for DVT or pulmonary embolism. They're not going to give you a 70-year-old man who never smoked, never used any kind of, let's say, steroids, no steroids, and he's healthy and exercising. They will never give you that kind of presentation towards DVT. That's kind of what I'm trying to bring across. So remember, pattern recognition is most common presentation of a disease that you will see in reality. Another example is sarcoidosis. USMLE will always tell you that sarcoidosis more often than not, and there could be exceptions maybe in step 2, but generally it will be in a female of African American ethnicity or descent who's 20 to 40 years old, so relatively young, not in 80 or 90, and has bilateral hilar lymphadenopathy. So let's say if this is a male, there's a male patient who's coming with lung issues and they are 70, the answer is likely not going to be sarcoidosis. It's going to be sarcoidosis generally with this kind of presentation. And that's something you need to hone in on, because the more you can do it, the more you'll be able to rule in or rule out things. And we'll again go back to the same question and use these same skills that I'm going to teach you. Second skill that you need to learn other than pattern recognition in test taking is clue recognition. And there are different clues the question writer will give you. So there are positive clues and there are negative clues. So if you looked at the previous question, what were some of the clues they were giving us? Positive clues could be she is dehydrated. That's a clue. That's telling me that there is a possibility that one of the answers is more probable than the others. Second clue could be there's postural hypotension, which she was having. So whenever she got up, she got dizzy. Third clue could be that she went to the hospital. So it is something serious. It's not something mild. It's serious because she went to the hospital. Those are positive clues where the question writers are trying to tell you where the answer lies, but it's up to you to figure out these clues and then use that to eliminate other answer choices to come to the answer. So that's a positive clue, which are very easy to spot. Everyone here can spot positive clues. The ones that are the hardest are negative clues. And there are two types of negative clues you will see. The first negative clue is a negative clue by commission. And the second negative clue is a negative clue by omission. So let me give you examples of what a negative clue by commission or omission is. So if somebody presents with, like in this case, if I'm looking at a certain answer choice here, so let's look at increased troponin. So let's look at that answer choice. If I'm looking at increased troponin and I'm considering that as an answer choice, I'm going to ask myself what in the clue, again, there are positive clues where she's dehydrated, she just collapsed, something happened. But what are the negative clues that are telling me the answer isn't increased troponin? So if you guys know increased troponin, that means myocardial infarction. So it's a lab indicator for the negative clues you need to consider here is, have they actively given you something which is telling you it is not MI? Some of that is cardiac examination. So they told you that cardiac examination is normal. Let's go back. Let me show you that. So you can see here that the cardiac examination is normal. And when they told you that cardiac examination is normal, that's a negative clue towards increased troponin, telling you that's likely not the answer. That's maybe something else. But let's say if they didn't give it to you, what else could you use? The answer is negative clues by omission. So commission is you're telling a person explicitly that something is normal so you can rule things out. The other is omission. You don't even mention information about the condition. An example is, do you see in this scenario if there is any chest pain? Let's go back to the same question stem. I want you to read this again. 75-year-old woman coming to the ED after losing consciousness, history of postural hypertension, history of AFib, hypertension, angina pectoris, currently taking aspirin, chlorothiazide, warfarin, nitroglycerin, afebrile, pulse is this much. Is she complaining of chest pain anywhere? And if she's not complaining of chest pain, that is a negative clue by omission. They haven't mentioned that. Is there any pain that's radiating to the jaw? No. That you're saying, is there any nausea that happens with MI? Are there any palpitations that you're getting? No. So the fact that they're not mentioning these things, they're not mentioning what should happen in the presentation of itself is a big clue to tell you it's not troponin. That can be ruled out. And this is where people screw up the most, is they are able to spot positive clues and sometimes some negative clues. They are like explicitly, these people are telling me cardiac examination is normal and that's why A is not the answer. But what they struggle the most with is this negative clues by omission, because this requires active generation. You should know a lot about the condition for you to generate that information and then rule it out. So now we are going to another cardiac examination is normal. That's telling you it's not pericarditis. So let's go back to the same question stem and use testing skills. Let's start dissecting it. 75-year-old woman presenting for loss of consciousness, that's syncope, and then she has a history of getting up from bed and losing consciousness. What is this? Postural hypertension, orthostatic hypertension here. She also has a history of AFib, hypertension, and angina pectoris. We'll note that down. Currently on aspirin, on warfarin, and nitroglycerin. So those drugs could have side effects and something to keep in mind. She's afebrile, pulse is this much, it's elevated, so she has tachycardia. Plus, let's look at other things. She has dry tongue, so there's probably some level of hypovolemia. Her blood pressure is low, hypertension. She has a dry tongue on physical examination, hypertension, more like some kind of fluid loss is happening. Capillary refill time is somewhat increased, so 4 seconds. Cardiopulmonary examination is normal. So when we look at these, and then let's go through the answer choices. Increased troponin, absent P waves, elevated BUN, 4 left ventricular hypertrophy, 5th is clot, 6 is febrile friction rub on auscultation. Let's go through why these could be answers or could not be answers. So if you told yourself it's increased troponin, I want to ask you a question. If this is increased troponin, let's look at the positive clues. She has syncope, which is an indicator. So increased troponin means myocardial infarction. And if she has syncope, that would fit in the paradigm of MI. That makes sense to me. And she also has a history, if you look at her history, of angina pectoris. So those are positive clues. There's also hypertension. She has cardiovascular risk factors and she's on drugs, aspirin. So those are some indicators towards MI. And that's why some of you said increased troponin. But what are the negative clues by omission and commission? If you look by negative clues of commission, the negative clues you're getting here by commission is cardiopulmonary examination is normal. Negative clue by omission here is that she doesn't have chest pain or she doesn't have nausea. So that tells me that doesn't really fit. That doesn't really make sense. So I'm going to rule this out. Now, second, absent P waves on ECG. Now, if you look at absent P waves on ECG, she has AFib. That happens in AFib. If you look at AFib, you can have absent P waves. Any kind of PSVT or supraventricular tachycardia can cause this. So AFib, she has a history of this. That's a positive clue. And she has syncope. So she has AFib and there's some hypotension going on. It could be AFib. But what are the negative clues by commission? Negative clue by commission here is look at her cardiopulmonary examination. That's normal. That's a negative clue by commission. So cardiopulmonary examination is normal. What else is a negative clue by commission here? Look at her rhythm. It's regular. So if she was in active AFib, the rhythm would be irregular and you would see absent P waves. That's how AFib presents. If the rhythm is regular, that means the AFib is currently in remission. It must be paroxysmal AFib and that's why it's regular. So regular tells me it's likely not this. So what I'm trying to teach you here is this. You need to balance positive and negative clues out. Positive clues that they give you, negative clues by commission and negative clues by omission. And because of that, this is not the answer. Now let's look at elevated BUN. If I look at elevated BUN, what are the positive clues they're giving you? The number one positive clue that you're getting for this is syncope. So there's probably that could happen with hypovolemia. What else gives me a clue here? Let's look at chlorothalidone. So she is on a diuretic. So she is on a diuretic, which could be causing diuresis and hypovolemia. She has tachycardia. Her BP is low BP and dry tongue. Capillary refill is increased. So those are positive clues. Now I want you to ask yourself, what are the negative clues in this? Negative clues in this. Could you tell me any negative clue in this? The answer is there is no negative clue. And this is likely going to be the answer, but let's see. I could be wrong, but let's see what else could be the answer. Left ventricular hypertrophy. So let's look at left ventricular hypertrophy and see why that could be the answer or not could be the answer. If I look at the positive clues here, this patient has hypertension and hypertension we know can cause left ventricular hypertrophy. That's one indicator. But she's also on an antihypertensive, which could prevent that. That's something that's going in my mind. But so if hypertension is causing left ventricular hypertrophy, number one, what are the negative clues for this? The clue number one is her current BP is low. She is hypotensive. That means her hypertension is pretty well controlled. And if your hypertension is pretty well controlled, that could mean the LVH never happens. It's a complication. So if that never happens, that could mean this is not the answer. The other clue they're giving you, which is a very important clue by commission, is look at her physical examination findings and cardiopulmonary examination findings. There is no S4. So this is a negative clue by both commission and omission, where you need to know like LVH causes S4 sound. And since there is no S4 sound, that is a negative clue, and that's telling you this is not the answer, even though there are positive clues. A clot in her popliteal vein on compression ultrasonography. So what they mean by that is DVT. And look at her, she's 75, doesn't fit the paradigm, not in OCPs, but we'll get into that as well. But what are the positive clues here? The positive clues, if I look at this case now, our number one positive clue for popliteal vein is she's a woman. That's a positive clue. Second positive clue that I'm getting is syncope. Third positive clue that I'm getting here is, what else are you getting? Tachycardia. So maybe that's caused a PE or something. So there are positive clues. But what are the negative clues here? If you had a popliteal vein issue or if you had DVT, what would happen? The DVT would cause some kind of erythema in the leg. Do you see any erythema in the leg? So no erythema. Do you see any signs of inflammation in the leg? Is she complaining of leg pain? The answer is no. And those are negative clues that they're giving you to tell you it's not the answer, which is 5, which is DVT. Other negative clues that they've given you by commission here, like omission here, is if she had DVT, if this was what are the hypercoagulable factors she has here? Maybe AFib, but that's not as much as an OCP. There is not that pattern that you typically see with USMLE questions. And that's another negative clue to this is not the answer. Friction rub on auscultation, that's our final choice. And we are going to look at this. So let's look at friction rub. A friction rub is caused by pericarditis. Okay. Let's look at the positive clues for pericarditis. So pericarditis, if it gets really severe, can cause a syncope, can cause tachycardia. That's another positive clue. Any other positive clues that you're seeing here for that? Not really. But what are the negative clues? Do you get chest pain in pericarditis? The answer is yes. In pericarditis, is the cardiopulmonary examination normal? The answer is no, because you're going to hear a friction rub. So there is no friction rub. So those are the negative clues, and that's telling me to rule this out. And you come to the answer, which is BUN. And again, this is the thing with USMLE. You could have all the knowledge in the world, but if you can't think critically, if you don't know pattern recognition, if you can't recognize positive and negative clues, you're screwed no matter how much learning you do. While other people who don't have even a lot of knowledge, even if they know the most basic things like cardiopulmonary examination is normal. If I just knew cardiopulmonary examination is normal and what that means, 1 is ruled out, 2 is ruled out, 4 is ruled out, 6 is ruled out. I have ruled out almost all answer choices, but the third one, which is elevated BUN, and the fifth one, which is clot. DVT could cause a PE, could not cause a PE, but that doesn't mean it could affect like cardiopulmonary examination. If I compare it to a normal jock who's giving USMLE, you currently have a 16% chance without testing skills to guess the answer, versus if I add testing skills, that increases to 50%. And this is the crazy thing that happens when you know how to solve questions. So my promise with this is it will be hard for you to not score in the 99 percentile if you follow this strategy, and you will not going to waste time preparing for the USMLE or money or energy. You're not going to delay it if you just use this properly. And again, it comes from somebody who is a live example of using this without having any extraordinary credentials. And I want to train you to let go of fear. Love this quote from Star Wars. This is by Yoda. And Yoda tells this to Darth Vader before he goes haywire and dark, is that you have to train yourself to let go of everything you fear to lose, because fear is the path to the dark side. He tries to convince Darth Vader before he becomes Darth Vader that do not go into the path of fear. And Darth Vader is too afraid that he's going to lose his wife, and that corrupts him. Because the reason is fear leads to anger, anger leads to hate, and hate leads to suffering. Through this, what I will ensure is that you're not going to be afraid. That's not going to lead to anger. That's not going to lead to suffering, which happens with why are they doing this to me? Why are the test taking people? Why are these USMLE NBV people screwing me over? Why am I so incompetent? The anger turning on yourself. That is what we want to prevent, and that's what I want to train you with this system. Okay. And just adding to this, you got to believe in yourself. This is manifestation 101. If you don't believe you can get a 260 or a 270, it will never happen. So even if anybody else says you're dumb or people tell you were never extraordinary, I had to do that to myself. I had to be my biggest fan. And I want to ask you to be your biggest fan in a world where everybody is trying to put you down. And just remember, believe you can do anything. and 260, 270 is nothing. Like it is a joke. And if you believe that it will manifest itself in a way, and again, USMLE is going to be super fun, and that's the goal. So how to play the game of USMLE on ultra easy mode. So I've walked you down through some test taking strategies, but the way you do this is learning on cheat codes and test taking on cheat codes. The typical USMLE step pattern that you should be familiar with is that it requires multi-level thinking and reasoning. So we just went through a question and you saw how that was not a single first order or second order or third order question. It wasn't simple. It was the opposite of simple. And that's what you're going to get throughout those 280 questions on step 1 and 320 questions on step 2. Questions will never be straightforward. You will need application, test taking. Mostly you will never get first order questions where they will tell you it's MI and they'll ask you what's the pathology. That will never happen. You need deep and strong concepts, not superficial knowledge to crush this test, and the ability to do differential diagnosis. So what I mean by that is whenever you're looking at a question, let's say in the previous question, the differential there was syncope. For the symptom syncope, there are multiple differentials. One differential is cardiac issues, which could be MI, or this could be pericarditis, or this could be cardiac tamponade, or this could be pulmonary embolism, which is causing the syncope. The other differentials could be, again, let's say DVT, which is causing a pulmonary embolism. Other differentials is shock, which is hypovolemic shock or neurogenic shock, multiple types of shock. What they will do is this. They'll take one big symptom and they'll make a whole question stem on this. And the answer choices you're going to get is A, B, C, D, E are all differentials of each other for that typical symptom, which you saw in the previous example that we went through. So MI, pericarditis, AFib, I forgot to add any kind of arrhythmia here. So if you look at arrhythmias, all of them are differentials for the same condition. And this is also another point you need to think about, because if you learn based upon just isolated learning, which we'll talk about later on as well, isolated versus combined or integrated learning. Isolated learning is when you pick up a certain subject like pathology or physiology. Let me ask you, if you went to the previous question, let's go to the previous question that we just went on. If you just did isolated learning where you learned biochemistry or physiology, do you think you'll be able to answer a question like this? The answer typically is no. And that's the problem. Our medical schools are teaching us on how to do isolated learning, which doesn't typically come handy in real life scenarios. Just learning biochemistry without combining it with pathology, anatomy, it doesn't give you the best results. An example, the way you want to be learning is integrated approaches, which we'll talk about, where you're looking at a certain condition and then you're dissecting it down through the lens of biochemistry, anatomy, physiology, pathology, and then interconnecting all of them. And that's how you answer questions. This is an easy question, by the way. This is not even hard. Most of the other questions are way harder. So that's what's going to allow you to ace this test. Not subject-wise isolated learning, it's integrated learning, and using elimination and using it to learn better. I want you to also type in the chat for me regarding if you were to do this question, do you think that me dissecting it with you, like one-on-one, just dissecting it here, do you think it helped you learn better from the question? Just doing those positive clues, negative clues. I want to just see that in the chat. If not, just let me know, but I want to just see major responses. And now imagine if you were to do that across your world, across all question banks, how powerful would elimination be? And let's say you don't. How would your learning be? If we did none of this, you just went through this question stem, you found out what the answer is, and you just read what's in UWorld or NBMEs. How would your learning be? Just going through those explanations that you go through. Passive. You're not going to learn as much. You're not going to learn how to differentiate different conditions. And that is what we call as meta patterning. So you might learn what's in the question, but you won't be able to apply the pattern that you learned across multiple global on the USMLE scale, across all those 280 questions, because you're not learning it through dissecting it. This is similar to anatomy. It's a very big difference looking at an anatomy book where you are reading about that fascia, Gerota's fascia, let's take that for example, versus when you're dissecting it and you're seeing actually feeling it through your gloves, through your hands, how it actually feels like, how it's actually going in reality. That's the difference in learning you get when you use testing skills versus not. Just taking you through the examples of what first order, second order, and third order questions are. So let's go through this question stem, guys. So what does this patient have? A technique that I would also want you to learn is what we call as a reverse A technique, where we are doing inverted question reading. The reason we want to do this, I'll go into this later on, is this is the most important part in the question stem. This is called as the key. And these are the answer choices. This is the second most important thing in a question. So the first most important is the key. Second most important is the answers. Third most important is the question stem. The reason you want to do this is because if I were to ask you to bring a certain item from the grocery store, where I'm telling you, let's say I need sugar. I just need some sugar. No puns intended, but I need some sugar. And you go to the grocery store and you get me the sugar. That's going to be an easy thing. You know what I want and you can get that for me. But let's say I just tell you to go to the grocery store. Just first go. I want you to browse the entire grocery store for me. And in the end, I'm going to tell you what I want. So you spend 3 hours through the grocery store, and in the end, I tell you I need sugar. How much time will you waste? That's the difference you get when you start with the key, then go to the answer choices and then read the question stem, is you know what you want, so you can get what you want easily. And that helps you cut down reading time by 25 to 30%, because you don't have to first read the question stem, see what they want, what are the answer choices, and then go back to the question stem. What you want is start with the key, go to the answer choices, go back to the question stem, and you're done. So you're not repeating, there is no redundancy, you're not wasting time. And this is the optimal way to read questions. But let's go through this question stem together and then you guys tell me the answer. What does this patient have? Turner's, Klinefelter, cystic fibrosis, Coleman. So 14-year-old is brought to the physician because she has not had her first menstrual period. She feels pain in her legs during sports in her school. She's at the 25th percentile for height and 60th percentile for weight. Her temperature is 36.5 degrees Celsius. Pulse is this much, 70. BP is 160/90. Examination shows high arch palate and low posterior hairline. The patient has a broad chest with widely spaced nipples. Pelvic examination shows normal external genitalia. There is scant pubic hair. I want you to look through the chat and see how many people got it. The reason so many people got it, vast majority of you, is because this is the first order question. Most of you will never get something like this, because all this requires is look at the symptom presentation and guess the condition. So one level of thinking. Let's make it a bit more complex. So same question stem. Now we are going to change the key. Laboratory examination will show what? Increased estrogen, decreased testosterone, increased FSH, decreased gonadotrophin releasing hormone, decreased estradiol. Which one is the answer? Tell it to me in the chat. So now, okay, I see high FSH, I see decreased gonadotrophin releasing hormones. So decreased estradiol. So now look at how many of you in the chat got it correct. The answer is it's less than what you did in the first instance. And that's because this is a second order question. You need to first look at the question stem based upon symptomatology diagnosed, which is Turner's. They're not going to give it to you. After that, there's another layer of thinking where you're applying also in Turner's what is the physiology, what's happening, what's the pathophysiology, and how is it abnormal compared to what you will see in normal humans. The answer is in Turner's because of ovarian dysgenesis, that ovaries are not working. Ovaries produce what? Ovaries produce estrogen. Because you have hypoestrogen, like hypoestrogenemia, and because of low estrogen, that's going to cause feedback inhibition to get inhibited itself. That's going to increase FSH and increase growth releasing hormone. Let's say even if you did not know the answer and if you could rule things out, I'm just applying test taking. Increased estrogen is out because it doesn't make sense. It's Turner's. Ovaries are not working. Decreased estradiol, like estradiol is a pregnancy hormone. You would need to know that, but let's say you didn't. But decreased GnRH and increased FSH. Let's say if you just had those. These are very contrasting answer choices. And that itself is a clue, because if you're getting contrasting answer choices, how is that both of them could be true? Generally, the answer is no. How can increased FSH and decreased be true? Because let's say if I wanted to rule these things out and they were similar, they said, let's say decreased FSH and decreased GnRH, that makes them very similar. And we call this similarity rule out. There's like thousands of patterns like this. But if they were similar, the chances are these could not be the answer and you could rule them out. But the fact that they're not similar is another clue that maybe it's increased FSH or decreased GnRH. So that's where my answer would have lied. Decreased testosterone doesn't make sense. It's a woman. Why would testosterone make a big difference? Unless it was increased, which is PCOS. So increased FSH, increased GnRH is where I would have lied. And that's a 50, or decreased estradiol. Though that's like compared to this, which is a 20% chance of guessing. Now I have a higher chance of guessing. So 1 in 3, which is 33%. Let's now go to a third order question, guys. Okay. So the same question, Now, let me ask you, what is she at the risk of? OCD, mitral valve prolapse, anosmia, osteoarthritis, or urinary tract infection, diabetes? Give the answer to me, write down the answer for me. Let's see how many of you can get that correct. So now I see osteoarthritis. That's something that people say. Mitral valve prolapse. Some people say UTI. Yeah, good answer choices, guys. Good guesses. The answer here, though, is let's think about it. So the number one most common comorbidity that you get with Turner syndrome is horseshoe kidney. And horseshoe kidney is when your kidney is abnormal and it's conjoined. So there's fusion, it's not separated. And that's horseshoe kidneys. When this happens, because of this anatomic anomaly, the ureters are not like fully well formed. There's issues with ureters and the pelvic system, the collecting duct system. And if it's not collecting because of this anatomic anomaly, we are going to get stasis. And if there is stasis, what is going to happen? The answer is a UTI. This is a third order question. So you have to first identify the condition, Turner's. Then you have to think about what is the most common complication, horseshoe kidney, and what is the complication of the most common complication or comorbidity. So that's the third order. Most of the USMLE questions will lie, at least for step 2, I know it's third order. Step 1, you will see a mixture of second order and third order, with third order being more common than second order. And that's what you need to prepare for, is get ready to be able to be doing this third level thinking. That is very quiet. And that's the main skill, test taking plus third level thinking, that you will see that separates 270s, 260s, 250s compared to people who get 220. So we're just going to be dissecting test taking skills just a quick more and doing some question stems before we will use these test taking skills before we go into strategy on how to prepare for step 1 and step 2 in the modern day era. So the first level of test taking hack that you need to know, or test taking strategy, is tactical empathy. Having empathy with the question writer, where you're asking yourself, what is why is there a question here? What are they trying to teach me? Are they trying to antagonize me? Are they trying to drive me crazy? The answer generally is not. They're trying to make you a better question solver, a better critical thinker. That's the point of the question. And when you can ask yourself, what is the point of the question? What are they trying to teach me? What do they want me to do? Or what concept do they want me to elicit? You'll be able to understand their rules. And then once you understand their rules, you'll be able to play that game and influence what the answer choice is based upon the rules. If you are playing it according to your own rules, you will never figure out the answer because your rules don't match up with the question writer's rules, and that doesn't match up with what the answer will be. So a good way to avoid question writing variability, which happens when, if you look at NBME questions versus UWSA questions, all of them are very different because they have different question writers. Even within NBME, there are different people who are writing the questions for different subjects, even for different topics. The way you avoid question writing variability is this. So NBME question writers are different from UWSA question writers. A lot of the times there is contradictory answers where one person will say this is the answer in NBME, the other person will say this is the answer in the UWSA. The way you prevent that question writing variability coming to the wrong answer just because the question writer changes is using tactical empathy, understanding the rules. And once you understand the question writer's rules for a certain question, it's a way higher chance you're going to come to that answer without getting confused by previous information, previous questions, and that's tactical empathy. So asking yourself before you do every question, what is the point of this question? What do they want me to elicit? What do they want me to learn? That's very important. Second is key. So importance of key and best possible choice. This is the second level. So I told you about the reverse A technique, which is the main reading technique that we follow in the USMLE. I want you to do this question with me and let's see if you guys can figure out the answer, okay? So let's start with let's say the stem of the question and then go to the answer choices. A 45-year-old woman is brought for chronic abdominal pain and fatigue. Her pain is epigastric, burning, and sometimes awakens her from sleep. She has no recent weight loss, nausea, or vomiting. Appetite consists primarily of fruits and vegetables. Patient also complains of a strange appetite for paper and ice that she has never had before. Upper GI endoscopy shows duodenal erythema and an ulcer on the anterior wall of the duodenal bulb, but is otherwise normal. Her unusual appetite is most likely related to which of the following? Oral leukoplakia, Bacter pylori infection. Okay, a 45-year-old woman presents with chronic abdominal pain and fatigue. Pain is epigastric, burning, and sometimes awakens her from sleep. Has no recent weight loss, nausea, vomiting. Diet consists primarily of fruits and vegetables. The patient also complains of strange appetite for paper and ice that she's never had before. Upper GI endoscopy shows duodenal erythema and an ulcer on the anterior wall of the duodenal bulb, but is otherwise normal. Her unusual appetite is most directly related to which of the following? A. Oral leukoplakia. B. Heliobacter pylori infection. C. Lactose intolerance. D. Chronic bleeding. E. Reflux esophagitis. F. Vitamin B12 deficiency. So I see F, I see D. Two options I can't think over B and E. So what the common pattern you will see in this question is this. First, you will see that there's this symptomatic presentation of abdominal pain, fatigue, these symptoms that she's having, along with some pain that's happening near the stomach area. Diet is like fruits and vegetables, strange appetite she's getting, and there's some duodenal erythema and ulcer. So something's happening. And based upon that, these are the answer choices we are getting. If you look at the answer choices, so based upon this presentation, so this is a 45-year-old female. I'm going to repeat it again. She has, which is not acute, guys. It's chronic. That's very important. There's fatigue. There's what else is happening. The pain is epigastric and it's burning, but she has no weight loss, nausea or vomiting. Diet is fruits and vegetables. So there's strange appetite that she has, which is pica. So if you have heard of pica, that's craving. Unusual things can happen in pregnancy or iron deficiency anemia. Upper GI endoscopy shows erythema and ulcer on the anterior wall of the duodenal bulb. So there is duodenal erythema. Something's going on the duodenal or erythema. Okay. So that's the combination that I'm getting, combination of symptoms. If I look at oral leukoplakia, that generally doesn't make sense because oral leukoplakia is cancer. And there's like positive clues, there's none. Negative clues, even if you did not know what oral leukoplakia, like had some idea, you can look at weight loss because weight loss is a pattern for commonly you have high weight loss in any tumor or a pre-malignant condition. If there is no weight loss, generally the answer is not in the line of pre-cancer or cancer. So that's, and is she smoking? Is she doing anything that will increase the risk of oral leukoplakia? That's the negative clue you're getting. So that's A. B is Heliobacter pylori infection. So guys, let's look at the whole question stem, the combination. 45-year-old woman has pain, chronic, it's epigastric, it's burning, and that's causing strange appetite. Can Heliobacter H. pylori infection, can that cause a peptic ulcer? Can the peptic ulcer cause bleeding? Can that cause anemia? Can the anemia cause pica? So that could be the answer. So B could be the answer, H. pylori infection. C is lactose intolerance. Lactose intolerance, generally, you would see her diet should have been like she's on fruits and vegetables. That's a positive clue towards maybe lactose intolerance because she's on fruits and vegetables and not dairy. That makes lactose intolerance a possible choice. But let's look at the negative clues here for lactose intolerance. What doesn't make sense for lactose intolerance is that the pain is burning. In something like lactose intolerance, you will have diarrhea and maybe some pain, but it's not burning. Also, another negative clue is no diarrhea. That's something you get with lactose intolerance. And also other findings of duodenal erythema, ulcer on the anterior wall don't really make sense to me. So lactose intolerance is out. We have ruled out A, we have ruled out C, and let's look at chronic bleeding. So if I look at chronic bleeding, that could also be the answer. So if let's say this is a peptic ulcer can always ulcerate in the anterior wall, there is duodenal erythema and an ulcer on the anterior wall, and that can cause bleeding, that can cause iron deficiency anemia, and that can lead to pica, which kind of makes sense. What are the negative clues for chronic bleeding? I don't see. So there is a negative clue that you will see. And the negative clue is there's no melena. Generally, if there is some kind of bleeding, at times you get melena, they complain of bleedy stools. That's the only like negative clue I can get for chronic bleeding. E is reflux esophagitis, which is if you have acidity, too much like acid production, and there's issues with your lower esophageal sphincter that causes the acid to come out, stomach acid, and causes ulcers, causing Barrett's esophagus and whatnot later on. But in reflux esophagitis, the positive clues are there is some pain. Generally for reflux esophagitis, you have throat pain, which you don't see here, but there is some epigastric pain, which could be an indicator. But that doesn't itself explain this condition. It itself isn't the most accurate answer for the key itself, which we'll talk about. And then there are other negative clues, because if there is no throat pain, that is a negative clue. If this was reflux esophagitis, she would have pain when she lies on the back, which doesn't make sense. In that gets worse. So reflux esophagitis gets worse with when you go lie on your back. So there's no postural variation in the pain. And that kind of gives me the answer that E is not the answer there. And F is vitamin B12 deficiency. Again, vitamin B12 deficiency can lead to anemia, but it leads to other things. Number one, she is on a diet of fruits and vegetables. Let's look at that. So fruits and vegetables she's taking. And apart from the fruits and vegetables, she has fatigue. So vitamin B12 can cause because she's not taking any meat products, she's on like kind of a vegan diet, that could increase the chances of getting B12 deficiency, and that increases fatigue. But what the negative clues here are: the ulcer, the duodenal erythema, they don't make sense to me. So F is ruled out. The only two answer choices are B and D that would make sense in this long thing. So if you look at the answer choices, B and D are the only ones that make sense. The rest you have ruled out. For B, it makes sense. D, it makes sense that this could be the whole condition. But then what is it? The answer is in the key. Her unusual appetite is most directly related to which of the following? The answer to his unusual appetite is what? Pica. And what is pica more related to? H. pylori infection or chronic bleeding? The answer is anemia or chronic bleeding. That's what pica is mostly related to. H. pylori itself doesn't, and they're asking you directly, not indirectly. H. pylori itself doesn't cause pica. It is more the manifestation. If you look at the chain of sequences: bleeding, iron deficiency anemia, pica, versus H. pylori, it's an added layer. You need to have H. pylori, that should cause ulcer, that should cause bleeding, that should cause anemia, that should cause pica. So that is the answer. This is why it is very important, when I was telling you on how to read questions, to not first look at the question stem, but looking at the key. So this is the keys. The first thing you should read is, if you want sugar, everyone wants sugar, you have to start with the key, knowing what you want. Second, go through the answer choices. Okay, these are the stores where I can go and get what I want. These are like the places or the aisles. So you're going to go across the aisles where you're seeing what you want, and that's the answer choices. And third, then you go to the grocery store and figure out what you want. You're collecting it fast, without redundancy, without wasting time. And that's the second level. First level is tactical empathy. So if I were to apply tactical empathy in this, the empathy is, so if I were the one writing this question, what is the point of this question? The point of this question is to make sure differentials of abdominal pain, and also what is causing pica. That was the point of this question. And if you know how the question writer is thinking, and the way they're going to present to differentials is through oral H. pylori, trying to confuse you with chronic bleeding and H. pylori. If you can figure out the rules, it just makes things so easy, and now you can learn better with this as well. The third level is what we call as combination theory. So we'll go through this question stem, guys, and the answer choices, and let's use the technique and let's see how well we do. The reverse state technique, where we are going through the key, then the answer choices, and then the stem. So the key here is, which of the following is the most likely cause of this patient's symptoms? They're asking the cause, and the patient, so the cause, like, must be the patient is experiencing some symptoms, and there are different causes that are given to us. There's bacterial meningitis, brain abscess, hypoglycemia, hyponatremia, medulloblastoma, thromboembolic stroke. So what I'm trying to see here is that there's a vast amount of conditions. Two of them are in a lump sum: brain conditions, medulloblastoma, also brain condition, thromboembolic stroke, brain conditions. So these are together. The rest here are electrolytes. So A, B, F, G is neurological issues. C, D, and E are more electrolyte issues. So if you look at that. So we went through the key, we went through the answer choices. Let's read the question stem together. So a 3-year-old boy with Digeorge syndrome is brought to the ED after a 5-minute generalized tonic-clonic seizure. For the past week, the patient has been increasingly tired and has had severe morning headaches, which have not been relieved with acetaminophen or ibuprofen. He has been dragging his leg for several days while walking. His appetite has decreased. He has been vomiting after waking up in the morning. Patient's family recently immigrated from a developing country to obtain care for unrepaired tetralogy of Fallot. The patient has a speech delay and a history of recurrent pneumonia and sinus infections. Temperature is 38.3. Physical examination shows tired appearing child with dysmorphic facial features. The lower extremity exhibits decreased strength, and the ankle tendon reflexes are hyperreflexive. The left lower extremity is normal. There is no truncal ataxia. Which of the following is the most likely cause of this patient's symptoms? So I want you guys to tell me what's the answer here. Is it bacterial meningitis? Is it brain abscess? Is it hypocalcemia? Is it hypoglycemia? Is it medulloblastoma? Or is it thromboembolic stroke? So I see some people have vouched for A. I see some B's. I see G as well. Somebody wrote G. Somebody wrote hyponatremia. So we're going to apply the way we do these things, and again, positive clues and negative clues. The way we apply positive clues is, if let's look at the answer choices and see what it could be. Bacterial meningitis. What are the positive clues that I'm getting here towards bacterial meningitis? So first of all, this guy just had a seizure. That's a differential. Guys having a seizure and this fever and whatnot. We'll talk about that. And then they're giving you differentials for that. So guy just had a seizure. He has severe headaches. So there's some headache that's happening. And this is not chronic, this is acute, happening over the several days. And these are happening in the morning. Headaches have not been relieved by traditional NSAIDs. So don't respond to NSAIDs. Okay. What else are you seeing here is there's issues with the leg for several days. He's not able to walk. There's low appetite. So some issues with the leg that's happening. Temperature is high, 38.3. There is fever, guys. Then he has history of recurrent pneumonia and sinus infection, which can act as a foci for bacterial meningitis. And then there's dysmorphic facial features, which is tetralogy of phalate. Lower extremity shows decreased strength and ankle tendon reflexes and is hyperreflexive. So the positive clues here towards bacterial meningitis, you can have seizures, you can have a fever in bacterial meningitis, you can have headache, you can have vomiting, which he's been showing. What are the negative clues here that you guys see for bacterial meningitis? Can you put it in the answer choices? No neck rigidity. That's a good one. Do you always have to have neck rigidity though in kids? But that's a good one. Space occupying lesion. Okay. So the best one I got here is this. Yeah. Photophobia. So what I want you to also understand is, like, some people are saying neck rigidity, some people are saying photophobia, and these are great negative clues that you're bringing up by omission that they could have mentioned. But I also want you to answer this. What is the sensitivity and specificity of different symptoms for bacterial meningitis? Does everyone who have bacterial meningitis have photophobia? Does everyone who has bacterial meningitis have nuchal rigidity? So the answer is no. But this is what I'm trying to tell you is you need to think through this, because if you were to just look at no neck photophobia, you would have gotten this wrong, because you would have said these are good negative clues. A is out. It is not the answer though, but still that's the wrong negative clues to be looking for, because these are rare negative clues. So rare symptoms. Every time I'm looking at a condition, I'm asking myself, if this is a symptom, is this seen in every time bacterial meningitis? Is it as common as these symptoms? Because let me tell you, fever plus vomiting plus headache are the triad for bacterial meningitis. They're way more common than neck rigidity or photophobia. So never ever rule things out just because of them being something that you know and something that are uncommon. So uncommon negative clues you have to be careful about, because that can lead you down the wrong lane. But the answer here is not bacterial meningitis because of one big negative clue that they're giving you by commission, which is focal neurological deficit. Look at his leg. There's a focal neurological deficit which is not allowing him to walk. And that's why bacterial meningitis is not the answer, because of that issue in his leg. So that's ruled out. But that's the negative clue to be using, not photophobia or neck rigidity. Again, neck rigidity is a great one, but doesn't happen in all cases of bacterial meningitis. And I'm not going to use it as a main negative rule out. But again, something to consider. B is brain abscess. So brain abscess is bacterial meningitis plus focal neurological deficit. You've gotten the meningitis, you're getting all the meningitis symptoms, plus you have focal neurological deficit with the abscess pressing on some brain structure, and that might be causing his leg weakness. So if you look at everything here, it makes sense. He also has hyperreflexia. That means upper motor neuron lesion, and that would fit into the paradigm of brain abscess. And there's no negative clues you're going to get here other than maybe photophobia or neck rigidity, which are uncommon. But these are again negative clues to consider, but not as common as you would think. So B might be the answer here. Let's look at others. Hypocalcemia. Is hypocalcemia the answer? What here in DiGeorge syndrome could cause hypocalcemia? So DiGeorge syndrome has hypoparathyroidism. So you have parathyroid anomaly. If there is hypoparathyroidism, guys, can that cause hypocalcemia? And can that cause seizures? Do you see seizures here? The answer is yes. Can cause some neurological issues like headaches? Maybe. Can it also cause other things? Maybe. But what it doesn't make sense with hypocalcemia wise is focal neurological deficit. That is a negative clue. Also in hypocalcemia, you should see tetany. Where do you see tetany here? I don't see tetany here. Other things to think about hypocalcemia, it can cause global hyperreflexia, not hyperreflexia, which is only isolated to left lower extremity. So that doesn't really make sense. Hypoglycemia, that's why I'm going to rule it out. Hypoglycemia, can it cause seizures? The answer is yes. Seizures can be caused. But does it cause the rest of fever, vomiting? Can cause vomiting, maybe fever, not sure. Focal neurological deficit, Probably not. It's ruled out. Hyponatremia, can it cause seizures? The answer is yes. Can hyponatremia cause global hyperreflexia? Sometimes the answer is yes. But does it cause fever? Probably no. Does it cause isolated neurological deficits? The answer is no. It's ruled out. Medulloblastoma, he's 3 years old. Can he have a tumor? The answer is yes. But look at one thing. So if he had medulloblastoma, guys, let's look at the positive clues. He is getting headaches. Tumors can cause fever. Tumors can cause focal neurological deficit. They can cause hyperreflexia, which is isolated because it's pressing on a structure. And it can cause decreased appetite. My question is, why is it not medulloblastoma then? That's a good negative clue. No sunrise sign, no fever. So everyone here missed upon one thing. So look at how long the symptoms have been going on for. So this patient has had symptoms for several days. My question is medulloblastoma a chronic condition or an acute condition? So that's what I was leading you towards. This is something you also have to consider. Is this acute or chronic? This is what people miss upon. Generally with tumors, it's more in lifespan of the condition is in at least months, weeks. Its months are more common than weeks, and that's how the USMLE functions. That's a common pattern you will see. If it's a tumor, generally it has to be symptoms going on for a couple of weeks or months. And based upon that, if it's not going on for a couple of weeks or months, you can safely rule it out. And that's why generally the answer is not medulloblastoma, but medulloblastoma could cause most of what you're seeing here. Yes, it can cause cerebral ataxia, which is correct, but that is another negative clue. And lastly, F is thromboembolic stroke. So look at the thromboembolic stroke, and so medulloblastoma can also cause seizure. Embolic stroke can cause all of what you're seeing here. It can cause fever. It can cause focal neurological deficits. Why is it not thromboembolic stroke? I understand the age is one factor, but he does have other risk factors. But that's a good catch that you guys have seen age. One way to eliminate it out. What else would you say is telling you it's not thromboembolic stroke? Would thromboembolic stroke cause vomiting?
Fever. There's no fever.
So by the way, strokes can have fever in the realm of USMLE. That's also another pattern. Not always, but can have fever. And he has a mild fever. So generally, if it's a stroke, the presentation is very acute. You will see it within a day and not across multiple days, which you're seeing here. That's one negative clue towards stroke. The other negative clues that you're going to get towards all of this is, yes, temperature is a great clue, something to take account of. No truncal ataxia, that's a negative clue for medulloblastoma that you're seeing. So no hypercoagulability factor. So this is the kind of questioning process I want you to do in your mind whenever you're looking through answers, because that is what is going to give you the best way to answer all the questions and get the 99th percentile that everyone's looking for. The last level of question solving we are going to go into is signal to noise ratio. This is looking at the positive clues and then the negative clues and then creating a ratio out of it. So let's say we went back to the question about syncope, or let's do this previous one where the patient had a seizure. So for seizure, they give you different differentials. There was a tumor in there. There were electrolyte abnormalities that you were getting. There was a stroke, and then there was infection. All of them can cause seizures. The way we were able to figure it out was looking at positive clues for each of these and then negative clues for each of these. Positive clues was what have they given you explicitly? Negative clues was your by omission or commission. What have they done? And then we take a ratio. This is where a lot of students lack the kind of question solving strategy and skill. Is they're not able to balance these things out. They're not able to weigh both the positive and negative clues and look at it through the combined lens. What they will do is this. Either they'll focus way too much on the positive clues. So they say seizure. The first thing they think of is seizure is caused by hyponatremia. And that's the answer. They don't think about the rest. And that's just giving into the positive clues, and you'll get things wrong if positive clues is all that you look for. Positive clues are signals generally. Negative clues are very important because as you went through this, we dissected this question stem, the answers. What you found was that the ability to just generate negative clues and look at, let's say, no truncal ataxia, telling you it's not medulloblastoma, that's very powerful. But if you focus on too much of negative clues, or if you give it too much attention, you will say neck rigidity, no photophobia. That means the answer is not bacterial meningitis or bacterial abscess, and you will get lost here. And this is a big disconnect people face, is that they weigh either too heavily, like initially. So initially everyone will start, when they're starting with the USMLE journey, with too much positive clue weigh. They're looking at too much of signals. That's it. Ignoring the noise, ignoring the negative clues. When they become intermediate, they start looking at negative clues, but they'll start ignoring the positive clues all of a sudden. The highest level is looking at them together, which we call a signal to noise ratio. Signals are positive clues, noise is negative clues, And throughout each question stem that you do, you have to build a signal to noise ratio for each of them. And again, you can always generate noise, and noise doesn't mean it's not the answer. So like somebody pointed out, neck rigidity, photophobia, it wasn't there in this question stem. The answer here is brain abscess, as we went through, because brain abscess can cause all these and has the least amount of negative clues. You would say negative neck rigidity or photophobia, but again, it's not as common. Number one. Number two, no other option choice kind of makes as much sense as brain abscess overall if you look at positive to negative clues. So you could have negative clues. That doesn't always mean that you can rule it out. So there were negative clues here, neck rigidity or photophobia. If I ruled out brain abscess, I would have gotten it wrong. And this is where people get stuck. You have to ask yourself, positive clues, what are the positive clues, negative clues, build a ratio and compare each answer choice towards that question stem. Okay, that's signal to noise ratio. And lastly, we'll just do one last question just to hone all of this in, the signal to noise ratio and the combination theory, looking at all the clues together and not in isolation. So let's read this. Okay, so which of the following is the most likely cause of these patient symptoms? Drug interaction, erosive gastritis, GI bleeding, mesenteric ischemia, occult carcinoma, pancreatitis. So 65-year-old male with non-ischemic cardiomyopathy treated with furosemide, carvedilol, lisinopril, digoxin comes to the ED with palpitations. His last left ventricular ejection fraction was 35%. His blood pressure is 160 by 100. Pulse is 130 per minute and it's irregular. Lungs are clear to auscultation. Abdomen is soft. Non-disc ECG shows AFib with rapid ventricular response and non-specific T-wave changes. Therapy with ribavirin and amiodarone is initiated with improvement in symptoms. The patient is discharged home after 2 days, and then these new medications are added to his initial regimen. 2 weeks later, he returns to the ED with profound anorexia, nausea, and generalized weakness. Which of the following is the most likely cause of this patient's symptoms? Is it A, drug interaction, B, erosive gastritis, C, GI bleeding, D, mesenteric ischemia, E, occult carcinoma, F, pancreatitis? Just drop the answer in the answer choices. So some people wrote, okay. I see A, I see C as the answer choice by some people. I see D. Anyone else? So let's look at the positive clues for each of these. Drug interaction, I'm not really sure what drug they're talking about. Maybe could be the answer. We'll keep it. B is erosive gastritis. So let's look at the positive clues. So what you're getting is like anorexia and erosive gastritis. So you're having erosion in your gastric layer. Probably there's an ulcer or something, and there's bleeding. Can that cause fatigue if there's bleeding? There's anemia. Yes. Can you have some kind of weakness because you have fatigue? Yes. Can you have some nausea because of the erosive gastritis? Gastric ulcers can cause nausea. So there are positive clues towards erosive gastritis that I'm getting. What else here tells me it's erosive gastritis is, let's look through everything. Okay, those are the things that tells me it's in like anorexia. They don't want to eat anything. Okay, those are the positive clues. What are the negative clues here that are telling me these are not erosive gastritis? The answer is not that. Let's look at his condition. If it were erosive, what else would you see? Would there be palpitations? Would there be any signs of bleeding? So no signs of bleeding, no palpitations. Do you get, and is there any specific kind of pain? Are they complaining of any abdominal pain? I'm seeing none of that. So because I'm seeing none of that, the answer is I'm going to rule this thing out for now. Erosive gastritis. Let's look at GI bleeding. If there was GI bleeding, same thing. It can cause what erosive gastritis can cause. Are you seeing any melena? It's a negative clue. Again, it might happen, might not, but no melena. Is there any pain that she's getting, or is there any other indication they're giving you for GI bleeding here? The answer is no. That itself is a negative clue. So generally, I'm going to rule it out because it doesn't really make sense. There's no bleeding, nothing GI that she's complaining of. For now, I'm going to rule that out. And her BP is okay. Look at her BP, no hypotension. They're not telling me vitals are abnormal. If GI bleeding was the thing, there would have been those negative clues. D is ischemia. Can mesenteric ischemia cause any of this? Yes. So this patient has hypercoagulability. If you look at his whole presentation, he has cardiovascular risk factors, non-ischemic cardiomyopathy. He has that. He has AFib, has hypercoagulability. And can that cause mesenteric ischemia? Yes, it makes sense. Can that cause fatigue? If you have mesenteric ischemia, what can happen? See, there's AMI and then there's CMI. It can cause fatigue, it can cause anorexia, it can cause nausea, and it can cause generalized weakness because you're losing blood. But if it was mesenteric ischemia, do you see any pain here? That is a negative clue. Apart from that, do you like acute mesenteric ischemia is the most painful thing people have. You don't see that here. Do you see anything else like any bleeding in the stomach, any melena? No. Do you see any vital signs issue? I don't really see that. E is also his AFib was treated. So he was started on rivaroxaban. So that should have decreased his hypercoagulability, but maybe the dose was so like low. I'm not sure. So mesenteric ischemia for now, maybe it is, maybe it's not, but I'm building the positive to negative clues and I still have it in my mind, but I will rule it out for now, but still in my mind. Occult carcinoma. Can occult carcinoma cause any of this? Can occult carcinoma, if this patient had stomach cancer or any kind of cancer, can that cause fatigue? Can that cause nausea? Can that cause anorexia or generalized weakness? The answer is yes. But if it was cancer, what are the negative clues that are missing? There is no weight loss. Okay. If it was cancer, there should have been some obstruction in the stomach or some other symptoms you were getting. I don't get any of that. There is no fever, low grade fever. There are no night sweats. And also, how long has his condition been going on for? Weeks? Can cancer happen in 2 weeks? I told you previously it's more months than it's weeks. And that's a common pattern you will keep seeing. And because that's not like this is happening in a span of just a few weeks after hospitalization. And that's why I'm going to rule it out because it doesn't really make sense. F is pancreatitis. Can pancreatitis cause all of these? Fatigue, anorexia, nausea, generalized weakness? Yes. But is pancreatitis painful? The answer is yes. Do they talk about pain? No. And that's why I'm going to rule out pancreatitis. Okay. So that's ruled out. So the only thing that remains here is drug interaction. So what I was just trying to teach you is if you even have lack of knowledge in specific domains, if test taking, this is the beauty of test taking. I would have ruled out B till F and come to the answer A, even though I don't know what the hell is going on here. The answer though A is drug interaction. What's happening is this patient is on digoxin. They started him on amiodarone, and amiodarone plus digoxin can increase digoxin levels because of this interaction. It's a CYP inhibitor. Digoxin is metabolized by that increases digoxin, and digoxin toxicity presents as profound anorexia, nausea, and generalized weakness. And that's why that's the answer that you were looking for. But this is the kind of dissection, clinical surgical precision you need to be able to answer most questions. And that is what generates insane amounts of confidence in me and other test takers to just crush the test and get crazy results. So how do you learn after you've learned test taking? The first thing is you need to use the right resources. Look at high yield topics, not low yield. Abdominal TB. Nobody gives a damn in USMLE about abdominal TB because it doesn't happen in the US. Nobody cares. If you focus on abdominal TB or rare presentations, it's a waste of your time because USMLE doesn't care. Progressive summarization and encoding variability are the strategies on how to get the best return on investment for your time using the right resources in high yield topics. Progressive summarization is a next generation technique in order for you to be able to learn information by compressing it down. Generally, what happens is whenever you're reading a book, you're starting with incredible amounts of context. Any book that's just, let's say, Genong, or let's look at Guyton. These books are meant to give you context. They're teaching you heart failure in deep detail, and that's good for understanding. But the problem is if you rely on these books for your USMLE, which is a resource which is too contextual or too big, it won't be concise or compressed enough for you to remember it, number one, and for you to execute in it. That's an issue. If you start with somebody that some review book like first, which is very concise, it doesn't go into as much as deep concepts as Genong or Guyton. It'll give you a nice review, but what it would lack is the contextual understanding or the basics or the concepts. So here what you're getting is execution. Here what you're getting is concepts. My question is, how do you bridge both of them? How do you make sure you're not losing context or understanding while also compressing down information without forgetting? The way you do this is through progressive summarization or highlighting 2.0. You need to build your own notes. I made my own notes on first aid. So what I would show this later on. I highly recommend watching my YouTube video on how to use first aid for USMLE prep. In this, I go into that technique. So what I did was I took a first aid layer, which was my book, and then I used my iPad and I would take pictures of every other resource and build a unified resource. And I would create my own first aid notes with every other resource piled, UWorld, all of them, so I could review them in the end, number one. But the problem is if I put everything together, the issue now becomes is that it is too freaking large. There's context everywhere. It's not concise if there's a unified resource. And that's the problem. And if it is not concise, I can't execute because I can't review. Then what you need to do is you need to highlight some portions of this. For example, bold passages. So if I'm going through first aid, I would make sure I highlight my notes on what is the most important thing within this. And then I highlight even further. I'll use another color. I'll start with, let's say, yellow, or let's say pink. And I'll initially highlight a few things in pink like this, okay, from my notes. And then to this, I'll highlight a few sub words within that layer to compress it even further. So what I'm trying to do is I'm building the context in my first aid, and then I'm compressing information as much as possible to look at what is the most relevant thing and not reading the whole thing. Let's say if you lose understanding and if you want to understand it again, how to do that. And then what I would do is I would mini summarize it. An example I can give you is like hepatorenal syndrome. If I were to learn hepatorenal syndrome, the way I remember it is hepatorenal syndrome is splanchnic vasodilation, which is leading to renal vasoconstriction. And if you have renal vasoconstriction, that's going to cause pre-renal failure. And that's going to cause your BUN by creatinine to maybe go up by 20. That's the thing. What you are seeing here is I've generated a mini summary, which is an equational. This is called as equational learning. You have compressed it so to the point that it has become an equation and you don't forget that equation. That's kind of the point. If I were to go back to my notes and read 2 pages on hepatorenal syndrome, I would go crazy while revising. I would go crazy just while rereading it or revising it or taking some time and just reviewing it. What you want to do is you want to build a summary. That's the final layer. And let's say you don't know, you want to get deeper into hepatorenal syndrome. You lack understanding. You want to go back and understand it further. You can go back from level 4 to level 1. So what you want to do is you want to concise everything down, and wherever you think you're lacking understanding, that equation doesn't really make sense, you want to use this layer and go back down into the layer 1, which is notes. And this is the best framework for learning that I have discovered till now. And this is what you want to be doing with everything in your first aid, is you want to compress it down to an equation. And then if there are doubts, you can go deeper and read everything. I would not recommend rereading entirety of first aid when you're doing your revision at all. That's progressive summarization for you. The next thing is encoding variability. So I'm asked a lot of the times, should I revise? And I would say, so my first aid, I think I just did it 2 times. So my step 1, when I read first aid, I read it first time with boards and beyond. The second time was just before the exam, about 2 weeks before the exam. So many people assume that means I'm not revising. Yes, I'm not revising if I'm reading it 2 times. Like a lot of people revise, don't get good results. How did I get good results without revising? The answer to that is encoding variability. So encoding variability means that you are attacking the same concept. For example, if I'm looking at heart failure, you could go through first aid infinity times to remember heart failure and you were going to forget it. But what if you first went to review heart failure from first aid and then you touched it on BMD. BMD took you through the heart failure, different types of heart failure, like shock, cardio, or is this restrictive, different like hypertrophic cardiomyopathy, whatever. So you went through first aid, you went through BNB, and then you did UWorld. And then after UWorld, you did NBMEs. My question is, what is better? Is it going through infinity times through first aid to review the same freaking topic over and over again without gaining more understanding from different angles? Or is it better to go through different resources where you're touching the same topic but through different lenses? What do you think would be more fun and more enjoyable and will give you the highest retention? The answer is different ones. That's what research shows us. If you look at language, why are we able to learn, let's say, Hindi, English? Why are we able to learn English rapidly fast without effort? Like we don't go and revise all the grammar, nouns, vowels over and over again. Why are we able to do that? The answer is encoding variability. When your parents start teaching you English, you learn what, let's say, compression means for the first time from your parents. You don't go back to the dictionary and keep repeating it until you go nuts. What you do is you learn compression for the first time from parents, and then you might forget it. But then what happens is you go to school. So the first time it is with parents in language. The second time you're going to school and you're relearning compression again. Third time you go to college, you're relearning compression again. Fourth time, let's say go watch movies, compression shows up again. What's happening here is you're getting the same knowledge given to you through different lenses. And this knowledge, this is called as encoding variability. Revision is when you're taking the same lens over and over again and going nuts. That doesn't lead to learning, that leads to forgetting. And you've tried it, you know that it doesn't stick. But when you look at language, or let's say you want to learn anything that sticks in your mind, the reason is encoding variability. You looked at through different lenses, different sources, and the way the brain functions, the brain thinks that if I encounter it in one scenario and I'm encountering it in different scenarios, This is important for survival. So if you look at like evolution, if I were to use evolution to explain it, in evolutionary times, if I were to, let's say, see one tree that has the perfect fruit that I want one time, I'm not going to remember it. But now if I start seeing it everywhere in different terrains and everywhere, my brain is going to remember it because it is important for survival. This fruit is very common, and because it is common, I should know like what it is. And other example I can give you is this. If you go down a path in, let's say, ancestral times, thousands of years ago, and you go down it only once, you're not going to remember it. But now let's say you're going through it different times in different directions. All of a sudden your brain will build the memory of it really fast because it knows it has to go through it in different scenarios, and it is important information for survival. And that's how encoding variability works, is you're taking the same information and you're using different lenses to learn that information, and that gives you way better retention and leads to learning that isn't tiring, it isn't fatiguing, it isn't constant freaking revision. So the way we are going to leverage that is through the strategy I'm going to go into for step 1 and step 2. For step 1 and step 2, I would say do an integrative strategy where you're not just learning path or farm, you're integrating that through the lens of a system. So for example, if I explore a cardio system, and let's say explore a subtopic, I'm going through the physiology, the biochemistry, the pathology. Physiology is what happens, what are the dermatomes that are affected, T1 to T4. That's how the pain radiates. That's some kind of physiology plus anatomical understanding. Other physiological understanding is like calcium depositing or what else is happening. Pathological understanding is thrombus rupture is happening in the heart. If I look at biochemistry, what else is happening? How is calcium moving across ions? Or CK, like how is CK getting out? Troponin, why is it important? Where is it stored? What is sarcoplasm? You're trying to link all of these together because that's how the USMLE will test you, and that's how real life works. You are not going to see biochem in isolation as a doctor. You're going to see a patient who has a condition, and then you're going to use multiple tools, which are your subjects, integrate them and help fix the patient. And that's the way we do that, is using first aid, going through it system wise, not subject wise, and then using different types of question banks, and then use encoding variability with it. Subject wise, I would not recommend. It is optional. Some people like to go by the route of Kaplan. And if that's something you want to do, sure, only if you have weak basics. But even after subject wise approach, you have to do an overall systemic integrated approach to get good results. Subject wise will cause you to fail. I'm serious. And do not recommend it as a sole strategy for main preparation. The main point, the main resource you should be using is a question bank, because as you saw before, if you want to do integrated learning and use critical thinking, just as you will do with a patient, and you want to learn test taking, which is the single most important thing in USMLE, that's going to be going through different questions and using differential diagnosis, elimination, the strategies that we went through. This is what causes long-term retention. And everything we just went through, you're going to remember brain abscess for the rest of your life. You're never going to forget it because you saw the question stem. You saw how to look at the differential diagnosis. You learn through comparison. And yes, like going through first aid is important, but not a question bank or any other resource. If you compare it, question banks are better. I would say it's even better than Anki, because Anki doesn't teach you this dissection that we just went through. So you avoid exhaustion because you're using encoding variability, and it's fun because you're repeating the same thing. You're not revising it, but you are also revising it, but through different sources. And that's way more fun. And you get a variety of clinical presentations of the same condition. So how does MI present? You might learn in a textbook chest pain, but sometimes MI, there are rare conditions in diabetes where the autonomic nervous system is affected because of autonomic neuropathy. You never get chest pain. And there are questions like that. But that's what it will train you, is to think in a very critical and clinical, like with clinical precision, rather than like having a very diffuse understanding, a vague understanding of a subject. In terms of question banks, there are two types of question banks you should be going through. The first one is a learning question bank, which is where you want to start. What we just did was we did a learning question bank routine where we were learning test taking, we were learning concepts at the same time, and it's messy. That's completely okay. But because we want to learn concepts, we want to learn to apply these concepts, we want to learn pattern recognition, clue recognition. Without this, we would fail. We don't want to start something UWorld first on, because what happens is if I were to start UWorld now the first time, the problem with this is this: you haven't learned pattern recognition, you haven't learned clue recognition, and it's like you're going to MasterChef after you've read a few cookbooks. What's going to happen is you're going to bomb any learning you even have on a big competition like MasterChef. So there's a very big difference between reading a book, and then after reading the book, practicing it, practicing all the recipes, and then going to MasterChef, versus reading a few cookbooks and then showing up on MasterChef. A person who has read books, who has executed on all the formulas in the books, on all the recipes, will actually might win MasterChef and might learn something from it to go to different competitions. Versus somebody who has just read a few books on how to cook will bomb it, and they're not going to learn anything, and they're going to waste the opportunity of MasterChef if they were in a competition, cooking competition. That's what happens with a lot of students in UWorld, is they started prematurely, and because they started prematurely, they screw everything up. And when they screw everything up, they do a second pass. When you do a second pass, there is no point. Because what happens is, if we went through this question, what they have is a basic understanding of, okay, this is going to be the answer. And when I go through UWorld, drug interaction is going to be the answer, the second pass as well. So you're not learning anything, you're bombing it, and it makes sense why people fail. It makes sense why they get low scores, is because they wasted the entire question bank, and then they show up to the NBME thinking that they can cook while they've just read books, never practiced. And because they've never practiced, they've never learned how to actually learn as well. So learning question bank is the waste question bank. You're wasting it to learn information, and assessment is not the goal. Test taking is not the goal. What you're trying to learn is information and some test taking. So let's look at learning question bank. Let's look at USMLE RX. That's the best one. So USMLE RX, and then there's UWorld, and then there's USMLE. What you want to do is just like MasterChef. What you want to do is, first, you want to cook at home to make all the mistakes. This is when you're learning test taking. This is when you're learning information. Only after you've done this, you go to UWorld, where you're actually going into, let's say, a mini competition, not MasterChef, like some kind of city competition where you're testing these frameworks out further. That's UWorld. So what you're doing here is you're improving test taking. So you already know the recipes. Here you have mastered the recipes. So mastered information and some idea of test taking. When you go to the UWorld stage, and this is when you're going to that mini competition, not MasterChef, your point is to master test taking, or master the exact variations of the salt or exact variations of spices you want to put. And then you go to the USMLE, where you both have an understanding of both mastering the material and then master the test taking itself. And that is the recipe for winning MasterChef and USMLE. Another point to learn is this. If I skip this stage, if I skip the USMLE RX stage, what is going to happen next? You're going to use this stage for mastering information and learning some test taking, maybe some test taking. Then you're going to go to USMLE prematurely without fully matured testing skills. The more testing skills you will develop, and the easier it will be. So the more layers of Q banks you can add between you and the USMLE, the higher the chance that you will master testing skills and information when you give USMLE. And that's kind of what I'm trying to give it as. If you start USMLE, UWorld, let's say UWorld is my only question bank. This is what happens. You go to your only question bank, you don't even know how to learn because you never learned test taking. And because you don't even know how to learn, you're going to just do two passes. You didn't even learn what was important. And then you show to the USMLE, NBMEs are not improving. That's the main issue that happens. So the way to fix that is keep adding question banks until your score gets better. We'll talk about what question banks are important. So if I'm preparing for USMLE Step 1, I want to first make sure I start with something like first aid. I want to start first aid with something like BNB and then USMLE RX. USMLE RX is a question bank by the first aid team. It goes hand in hand with first aid, and I would do them together. Then after I'm done, like I'm doing these together, maybe add Pathoma and Goes and Beyond you're doing, and maybe add Sketchy is visual mnemonics for first aid. So all of these are like different offshoots of first aid where they're trying to build more context, like we talked about. So you want the review book, you want to add context to it, and then you need to use progressive summarization to create a unified resource, and you have like concise notes that you can remember. After you have done this, you want to go to UWorld. You don't want to go to UWorld prematurely because you're not going to learn much from it. Subject-wise resources, if you want to use, these are the list I would recommend. If you're weak in a particular subject, if you are just, let's say, starting med school and you have time, again, you can take some time, go through Kaplan. Kaplan is a wonderful resource, and then go through these resources that can be helpful. I would study for step 1 in 2 phases. The first one is consolidation. This is when you're learning the information plus you're learning some of the test taking. First stage we were talking about, where you're using USMLE RX and learning test taking. Second is execution, where you're using U plus you're using, let's say, NBME question bank or NBME is 1-2 or CMS forms. And generally 7 months is what I would recommend for step one prep. Some people will say it should be shorter. I would say no, because step two is 60% step one. So even if you take longer in step one prep, you're ensuring your fundamentals are clear, and step two just becomes way easier. So it's contributing to your step one. So it's not a bad thing. You shouldn't feel guilty about taking more time on step one. This is the schedule I will recommend that I have done and all my students have done. For step one, you can take a picture or a screenshot. I'll see if I can send a recording if it's possible, but that's the structure I took when I was going through my exam. The first 3 months were more so about doing BNB first aid, and the last 3 to 4 months were more so the execution phase, where I was doing UWorld plus NBMEs, getting my test taking skills up. Consolidation wise, the first 3 months should be heavily focused on first aid plus adding. So this is the concise resource. You want to add context by adding boards and beyond. You need to add some sketchy, which are visual mnemonics, and active learning in terms of using USMLE RX. I used to do 40 to 60 questions a day. I would start a question, go through the answer in USMLE RX, and then the explanation is the first aid page. That's the best thing. So whenever you do USMLE RX, you can learn first aid through a question-based lens, and this is called as QFAR, question-based first aid revision. So I did BNB plus first aid. That was first time encoding variability was used. Second time encoding variability was used is USMLE RX, where USMLE RX took me through first aid a second time. It takes 2,000 questions. You should be like easily done with this in 3 months, because if you do, let's say, 40 questions a day, and this is when I'll be learning clue recognition, pattern recognition, and making sure my testing skills or cooking skills are good. Consolidation extras you can consider is sketchy, Pathoma, Picmonic. They're like, if you want to go through this, go to my playlist and watch the video in step one. I go way deeper into this, because this itself, what should you cover in Picmonic, what you should not cover in Picmonic, is a huge topic. Pathoma, BNB generally covers whatever Pathoma covers, but if you struggle in pathology, this could be added, and if you have the time. Last is execution. Like I told you, if you want to influence somebody's behavior, or if you want to understand how to win a game, you have to first learn their rules. And this is where execution comes in place. You don't want a poker face in front of you. You want to be able to read through the poker face so you can make the best guess, just like you do in poker. That's how you win poker, is by guessing what they're trying to tell you and then what hand they have. And based upon that, if you can guess what hand they have, you play your hand. And that's where execution builds, is you're refining your test taking skills. You're making sure you're ruling things out in the way and making sure you're not ruling things out in the wrong way. Execution wise, I would say UWorld is the best resource. It should be taken more of an assessment tool than a learning resource, which is contrary to whatever you'll find on the internet. The information you should be taking is from top test takers. Don't learn from people who haven't performed that well, because they will tell you it's a learning resource. That is, yes, it is a learning resource, but you should be using it to see that your scores are going up and you're executing well on your testing skills. Plus, you should learn from it. But learning is not always just the sole focus. Employ test taking skills. Calibrate. Calibration is very important. See where you went wrong with positive clue recognition, negative clue recognition. It generally should take you about 3.5 months. I would review everything from getting the thing on the question to the wrong thing, because sometimes you can get a thing, let's say a question for the wrong reasons, which you don't want. Because if you get a question for the wrong reasons by fluke, you're learning the wrong thing, and then you're going to perform bad on the USMLE, and that's what we don't want. And what I would also be doing is, whenever I do UWorld, I would take screenshots of whatever UWorld questions I got, let's say like any kind of explanations or summary. I would take a screenshot of that and put it on my iPad on my first aid. So I was building a unifying resource, and that's called the unifying protocol. UWorld again should take you 3.5 to 3 months. Do it on time plus random mode. The reason you want random is this. Because if you do system wise or subject wise, the problem is this. If you do system wise, let's say cardio, the problem with UWorld is, if I start with cardio, the answer generally will be, let's say if somebody has chest pain, the answer is never going to be flu. The answer will be M. And because you can already guess the answer, you're not using test taking skills. If like it's a cardio question, it's a cardio answer, that you're missing out on very important learning points. And that screws people over time. So that's why we'll never recommend system-wise or subject-wise, because if you use these approaches, you're giving yourself an unfair advantage, which will make you not learn testing skills and which will over time complicate things. So always do random, because that will train your testing skills to the best. max possible. Time, because you want the time pressure, USMLE is not going to give you unlimited time. I would only do UWorld for one pass. I would not do a second pass because the second pass is a waste of time. This is not just me. Every top test taker will tell you not to repeat UWorld because it is a waste of time. You're not learning test taking. You already know the answer. What you want to do instead is maybe a new question bank. I would recommend Amboss if you have the time, or the NBME's question bank, which is all the NBMEs pooled together, just going through them rapidly and seeing how you perform. And how to proceed if UWorld is the only question bank. Again, UWorld, you're doing 40 questions a day, 1 hour each, and then 4 to 5 hours for 1 hour for a 40 question block and 4 to 5 hours for that block review. Explanation, take your time, 6 to 7 minutes. If you got something wrong, take even longer. If you don't know anything, make sure you're not wasting that question. Because the second, like I would not go about it the second time because it is a waste. I would make flashcards on my first aid. If you want to do it on UWorld, you can do it, but I wanted a unified resource where before going to the exam, if I wanted to just glean through things, I could do that quickly. And other question banks, similarly, 40 questions a day. If you want to add, maybe add NBMEs or maybe add something else like Amboss. And in execution, you're going through NBMEs. I would recommend do as many as NBMEs possible. The latest ones for sure. Free 120 is a free resource by the USMLE. The new free 120 and the old free 120 are highly important. And then UWSA 1 and 2, of course. And Amboss also has a free assessment if you just want more questions to test yourself. UWSA, I did this in my like 5th month and 5.5 months out of a total 7 preparation, but you want to keep it towards the end, the last few weeks. NBMEs 25 to 31, as much as you can do. Best case scenario, all of them, at least one if you don't have time. And NBMEs are the most important. So this is what I will tell you. One of the big strategies for anybody who scores really high on the USMLE is they do almost every NBME in existence, at least NBME 15 onwards till NBME 31. Because what happens is this: if you look at UWorld versus NBME, they don't have the same test writers and the questions aren't always the same. You will notice that. UWorld at times for step 1 is less convoluted than NBME, which is more convoluted. It's more complex. And because of that, your testing skills might not be calibrated to the same level for NBME, like after you've done UWorld. So generally what you want to do is, if these people are writing the USMLEs, you want to train on their material as well. And this is one thing you will see with every top test taker is they've done almost every NBME in existence. At least NBMEs to 31 is what I would ask of you. So you're trained in NBME's language. For step 2, I can give you an example where UWorld sometimes can be contradictory towards NBME. An example I can give you is if you look at spinal trauma in step 2. UWorld says if somebody presents with spinal trauma, do CT. That's the answer for UWorld. NBME says if there is a spinal trauma, you have to go through the 3rd order question and then the answer is X-ray. So there's a big discrepancy at times between what UWorld says and what NBME then and because of that, people get questions wrong on USMLE because they never trained in NBME material. The reason NBME says X-ray is because it's cheaper and it's better to get that before we do, but the standard of care is CT scan. So just knowing that, I think, is very important. Just how the NBME question writers think is they're training you on affordability as well. So you're also asking what is the best evidence-based next step, plus what would also be an affordable step here. Another example I can give you where there is discrepancy between UWorld and NBME is anorexia nervosa, where UWorld will tell you anorexia nervosa, if there is less than 18.5 BMI, you do inpatient hospitalization. But if you look at NBME, there are questions where you treat them without inpatient, you just do outpatient management. Because the new criteria erases the 18.5 requirement. You no longer have to have the BMI lower than 18.5 to have inpatient hospitalizations. So sometimes this is what happens when you do too much UWorld, you might get NBME questions wrong because you're either overthinking or the information isn't always synonymous or doesn't always translate. And that's why it's very important to do NBMEs. Lastly, execution review. This is the last 2 weeks. Go through free 120, review first aid. This is your unified resource where you pulled every resource together. Use reverse progressive summarization where you're looking only at equations. That's what I did. And last 2 days before the exam, don't study. I wouldn't recommend that because it will add to your cognitive load. And that is going to interfere with your exam more than the last 2 days of prep. Lastly, step 2, we'll just blaze through this. So step 2 is the #1 predictor for getting an interview in the whole match process, and also is a predictor for you getting ranked like step 2 score and step 1 when it was scored, that was something as well. But step 2 is also predictor for interviewing and ranking. So it helps you match if you have a good step 2 score incredibly. And USMLE step 2 is about 60% of step 1. If step 1 is deficient, that will hurt you on step 2. And step 2 doesn't have as many as resources, which complicates things even further. Resources wise, I would start with Anki. I started with, I'll go into which Anki deck just to scope the subject, not to train yourself on. Then I would do UWorld, Amboss, Divine Intervention podcast, and the book I would follow is First Aid for Step 1. Okay. In terms of consolidation phase, so this also has 2 phases as we went through with step 1. Consolidation phases is when you're consolidating information, and then execution is when you're executing on it. Because step 2 is vast. So you need to know what are the boundaries of step 2 to see what to learn and what not to learn. I use a deck called Tazanki deck. If for anyone who stays till the end, I'll share the link of all these resources and you can get them. I started with Tazanki deck. It is an Anki deck, which is a pre-made Anki deck. You can just Google it and also find it yourself. It is a combination of all you and Amboss questions. And what I did was I opened it on browse mode, which means I didn't go through the traditional Anki algorithm where it's using spaced repetition, because that's a waste of time for me. What I did was use that browse mode to go through each card once, not multiple times. And it took me like 100 cards a day. And 500 cards a day, that's how much I did. And in about 2 weeks, I was done with all of step 2 scoping, which is learning what were the boundaries, what should I learn, what should I not learn. That's how I did it, because step 2 is like vague, it's vast. You need to build boundaries. This is what will help you build boundaries. After you've done that, I would add Divine Intervention podcast. If you have time, do everything. If you don't have, the highest yield ones are military series, clean ST series, risk factor series, and ethics series. Consolidation phase, again, here comes with the CMS forms from NBMEs. These are clinical mastery shelf forms. There are about 9 subjects, and you want to be doing clinical. There are about 2 to 4 CMS forms per subject. There are about 31 CMS forms in existence. Each CMS form has about 50 questions for each subject. So family medicine, you will see maybe 2 CMS forms by the NBME. These are like these, but subject specific. Each CMS form will have 50 questions. So for example, family medicine, you'll have 100 questions. Or let's say for internal medicine, if there are 4 CMS forms, you'll have 200 questions. This is very high yield because if you look at the data, a significant predictor of your step 2 score is how well do you do all these CMS forms and how much of them you have done. The more the CMS forms you do, the higher your step 2 score generally is. And a total is 31. I would say if you have time, do 31. If not, minimum 2 per subject. NBME charges about 20 per CMS forms. So based upon how much ever you can afford, do CMS forms, highly recommended. UWorld is part of the consolidation phase with the CMS forms. That's where you're learning most of the information, consolidating most of the information. In the assessment phase, you want to be using your UWSA 1, which I did at 3rd month of my preparation, UWSA 2, which was at my 4th month of preparation. And then assessment phase, I used the NBMEs. Here they are called the CCSSAs, 9 to 14. There's 5 of them. I would do at least 2, but if you can, do all 5 because it's a significant predictor of your score going up. I did them at my 4th month to 4.5 months of preparation. My step 2 prep took about 5 months, if I remember correctly, 4.5 months to 5 months. I would do free 120. This I did at the mark of my 4.8 months, which is about 2 weeks before my exam. And the last week I just reviewed my notes. For step 2, what I did was I built my own notes where I just looked at UWorld, whatever information I was lacking, I would add to the notes from UWorld, from Divine Intervention podcast, from Anki or whatnot. Everything was consolidated in one resource just to be revised one day before the exam. That's it. But again, I would not worry about revision as much as other people do because you're using encoding variability where you're starting with, let's say, Anki, and then you're adding UWorld, which will tell you the same thing in Anki, but with a different lens. Now you're adding maybe with a different lens, same information. You're doing kind of a revision, but through encoding variability. 4th, you'll do CMS forms. 5th, you'll do NBMEs. So you're already having multiple revisions through different resources, which boosts your score even further. Guys, thank you for being with me. I will be sharing the resource with you as well as we go through the end. But before we do that, I want to ask you another question. Imagine waking up the day before your exam and knowing you nailed it. That's how I felt. And that's how all the toppers feel. And imagine a world where you have zero exam-related self-doubt, anxiety, frustration. You're not confused with each answer choice. You're just not stuck between different answer choices. You're not overthinking. You're not underthinking. There's no constant dread, anxiety regarding the next block of questions, what's going to be the next question on the USMLE, on my NBME, and you're not overwhelmed by resources. Because that's how I felt through test taking. And a world where you're excited about steps. This is how I felt. This is how all the top test takers, if you talk to them, they're excited about their steps because they're not worried. That's the world I want to bring to you. And that's why I wanted to introduce to you for anyone who stays till the end, because those are the people I want to work with. And that's our course, which is USMLE Exponential Catalyst. It's our 6-month live course where what we want to do is we want to transform you from a prisoner of the exam, because that's what students tell me. They feel like a prisoner where they can't control their score, they can't control the outcome in any way, and that's a shitty feeling. I want to convert you from that to a USMLE assassin like me and other people who can just cut through questions. It is easy for them. They don't have anxiety, no self-doubt. It's all gone and it's fun. And this I want to do with our 6-month live cohort. And in this, what we will be doing is it's a live, not recorded classes, live mentorship. You'll learn from elite test takers and we'll do questions from the NBMEs together. And what we will be doing in all of this is we'll be for step 1, we'll be covering NBMEs. Step 2, we'll be covering all CMS forms and NBMEs, because you want to learn from NBME's own logic, their own test takers, because that is what's going to come on the USMLE, not UWorld. And this is a big problem with people who don't score high, is they never get the chance to go through all the NBME questions. And this is the highest yield thing in the end, which people miss out on. So I want to do that with you, with the experts who have scored a 270, including me. We have people who have scored 280s who are going to be taking you through, let's say, 30 to 40 questions of NBME every other day. So for step 1, it is going to be 3 days a week. For step 2, we are going to be doing it 3 days a week as well for 6 months. We use our N+1 coaching technique, which is anybody who's teaching you step 1 or step 2 material has done step 2, at least for step 1. So they have taken the next level as well. So if I'm teaching you step 1, I have done step 2. So if I'm teaching you step 1, I can teach you information as you're learning step 1 material, which will be way, way better than you learning step 2 material separately. I'm encoding that while we are doing questions. I'm telling you, this is how step 2 will differ. This is the mistake you will make in step 2 if you do it this way in the step 1 realm. If you are doing step 2, it is somebody who is given step 3. If you're taking a step 2 live mentoring and coaching through all the questions, we'll be taking you through our test taking skills on how to dissect question stems, on how to learn them. So there is that N+1 approach, which nobody in this industry offers, but only us. And that's, I think, how it should be. And that's how I learned from people who are like one step ahead of me. And this is updated for the 2025 USMLE syllabus. If you look at Kaplan, if you look at other resources, they're not following the 2025 syllabus. If you ask people who are doing step 1 now, it is way different from what it used to be about a few months ago, if not years ago. So people learn Kaplan and then they're surprised that when they go to Kaplan, they don't know anything, because the whole USMLE is different, because it is different now. If you look at step 1 now, why do N+1 coaching too? Step 1 is shifting from pure step 1 questions to step 2 material added to it. And if you talk to anybody who's given the most recent USMLEs, they will tell you there are step 2 questions showing up on step 1. There are questions about next best step, which is they're asking you about the next best step, which like from what to do for that condition. For example, if you have a heart attack, they're going to tell you we do a PCI. PCI fails. What is the next best step? That's the questions you're going to get at times on step 1 now, because that's the new syllabus. It's updating on step 2 rules, and they want more critical thinking, more meta thinking, especially with how good AI is getting at solving questions. They want people who are even better. During this, we'll be taking our N+1 coaching approach, because we want to solve for that for step 1 and step 2. I also like step 2, you'll see step 3 questions pop up all the time. And that's why I want somebody who's done step 3 and crushed step 2 at the same time teaching you step 2 material, and somebody who's done step 2 and step 3 teaching you step 1 material, because they can give you that integrated approach that other people are not learning from. And this will be through like what I just took you through. That's exponential advantage. That is what 40,000 plus students have followed across the past 5 years in scoring 280s, 270s, 260s. And that's the recipe we'll be using to take you through all entire NBME question bank, dissecting it for you, so you're learning the thing and not the wrong thing. And what's included in the program, it's 6 months long with 3 weekly live classes. All the questions are NBME curated, which is we don't want to do anything outside of the NBME, because it doesn't even make sense. Why would I teach you just UWorld stuff if you can do that on yourself, but it's not even that high yield compared to NBMEs, which you're missing out. So everything is NBME focused, because that's the single biggest correlation between somebody's score and like NBME question, like how much of that they have done. That is the single biggest correlation I have seen in the USMLE. We'll be teaching you our whole testing strategy, how to eliminate. What I just showed you through elimination is 1% of what elimination is. It's nowhere near the full course. It will take at least 6 months to hone those skills into you and teach you how to rule things out, rule things in, and not make mistakes. Because that thing, that if you use it in the wrong way, can hurt you too. So we gotta be careful. The tool is as important as the person using it. And that's why exponential advantage is the most powerful thing, but people just don't know how to use it. And this is my way of teaching you how to use that. And you'll be getting live support from our WhatsApp group. We'll add you. You can ask any questions. We'll be there for you any day of the week. Our proven results. So if you go through my channel, if you go through my courses, step 1 gains is 37 points on the NBMEs. That's the average. The minimum we saw was 14. Maximum we've seen is 43. For step 2, our average score gains are 32 points from the most recent NBME, and then the next NBME at least 32 points gained. The minimum for this is 16, maximum is 37 point gain on the step 2. Our pass rate is industry leading. Nothing in the industry touches this. It's 99.85% because you're learning from tests, questions, which are the most important. And we have already transformed 1,750 plus students. If you ever want to talk to one, I'd be happy to connect you. And a lot of my students are currently doing residencies all across the US. Our satisfaction guarantee is this: we'll be there for you until you pass. Even though the course is 6 months, let's say you want to take time or something happens, we're going to stick with you for free without charging you extra money, nothing. And we'll give you extended support, whatever it takes to get you to pass step 1 in time. And make sure you score well on step 2. We'll be there. That's my commitment to you. And lastly, what is the investment for it? This program, if you were to ask anyone before like joining, was $2,599. That was how much we are charging. But just because you stuck with me till the end and you're interested, like those are the kind of people I want to work with. I'm just giving it out for now for $1,499 for our entire 6-month live experience. If you make the payment for the first time in info, if you want the monthly option, let's say you want to take less months, you can pay $349 per month. I have the best tutors working with me, and it takes a lot of finances to make all of this work. And this is unlike private tutoring. So if you look at any other tutor and you want to learn testing skills from them, in America, the tutoring rate is $350 to $500 an hour if you want to sit with them. They don't have any curriculum. They don't have a proven system. They haven't tested it across thousands of students. $350, even if you took 10 hours for each of these, let's build that range. It's $3,500 to $5,000. And in this, there is no consistency, there is no reliability, there is no structure. What I wanted to build was I wanted to build the best coaching program for this with a proper structure, where we are giving you information, like teaching you the current USMLE syllabus from NBME, from the real test takers, not people who have never given the test, which you will see with other places or centers or whatnot. And this is through the lens of questions. I think that's the best way to learn. And if that is something you are interested in, you can join. Again, we don't have many slots. We have already filled most of that cohort. That goes away. I just had a few seats that if you want to join, let us know. Our next cohort, we have 7 seats left for step 1. For step 2, we have about 15 seats still left. What we want to do is we want to transform your experience. We want to make USMLE fun in the end. We don't want it to be a source of suffering. We want to teach you how to be so confident that you're not afraid of that exam. And who will benefit the most from it? If you're a first-time test taker, you're just starting your USMLE journey, you're in med school, you're out of med school, it works. We have tested it across all domains. And if you're a test retaker, you have an attempt. We have tested it across people who have attempts, and they have scored fantastically. So if you're interested in joining, let me just write the WhatsApp number that you can use to sign up for it. +1 919 201 5700. Okay, that's our WhatsApp for me and my team. You can get in touch with us if that is something you're interested in.